Irfan?
Yes, I will speak.
I hope you can see this slide. I'm sorry.
Uh,
You are breaking up.
Okay. Good morning, madam. I welcome all of you to today's session, webinar session on the topic assessment of lipoprotein little a value in cerebrovascular accident cases of Tripura. So this lipoprotein little a was discovered long time back, but it was ignored for a long time. Now I'll tell a little background history. When I was preparing for another cardiac troponin key, at that time I noticed this troponin that lipoprotein little a, though it is a causes some disease and it is mentioned that it was only a risk factor, but it was not included in the conventional lipid profile. So it it is not was not clear to me why it was not included in the normal lipid profile. So I thought I'll go further. So afterwards, I find in the literature that this lipoprotein little a is widely distributed among the population, and it is high in African population, but they are having HDL high, so somehow prevented from a cardiovascular event. Now, lipoprotein was first described by Barth in 1963, and it is actually synthesized from apolipoprotein gene. And if you see this gene, when it comes to the when it is synthesized in the liver cell, then apolipoprotein is added with the LDL particle. And LDL particle, we know it is a bad cholesterol, but this lipoprotein little when it is combined by disulfide bond, then whole character of LDL is changed and it assumes new name, that is we call lipoprotein little a. And lipoprotein little a, all the phospholipid, cholesterol, ester, whatever is present, it is made oxidized and it is very much prone to develop your cardiovascular disease. Next slide, please. So we can see here when this is the lipoprotein molecule, when it is connected by disulfide bond to the apolipoprotein A, then the whole LDL particle is changed to apolipoprotein. Is changed to LDL particle, and LDL particle having pro thrombotic, pro-inflammatory, and pro as atherosclerotic also. So it is when it is combined with the apolipoprotein, its nature is totally changed to a character which is responsible for all the atherosclerotic cardiovascular disease. So that is the main crucial point where it is combined with by disulfide bond with the ApoB100 and apolipoprotein A. So next slide, please. So the same thing, lipoprotein A, low density lipoprotein, it combines with the composed with apolipoprotein A, and it is having a wrinkles repetitive structure that is called ringle, and that name is coined from Scandinavian dish. So that is the in short structure. Next slide, please. And here we can see the green colored apolipoprotein, and it is combined with ApoB100 by disulfide bond that already I have mentioned. So next slide, please. Here also it is simplified view of apolipoprotein and ApoB100. Okay, then next. So it has been suggested that coronary risk factor, independent of increase in other serum lipid, that point is important. It is coronary risk factor, but how much it is detrimental to our health. But in the below it is written, independent of increase in other serum lipids. That means cholesterol may be high or low, triglyceride may be high or low, or patient may be hypertensive, but still smoking, obesity. So when apolipoprotein is combined with combined with LDL, then it becomes apolipoprotein, and that is more dangerous than conventional. So if a patient comes to the physician or cardiologist for treatment, if it is hypertensive, then they will do the conventional cholesterol, LDL, VLDL, everything. And after treatment, if it is normal, they will say that you are safe. But if a question is asked whether it is safe for cardiovascular risk factor, that answer cannot be given, because unless we estimate the apolipoprotein A, unless we estimate the apolipoprotein A, nobody can tell whether he is having a risk for future atherosclerotic, cardiovascular, or cerebrovascular accident. So it signifies that apolipoprotein estimation is very much essential for preventing the ASCVD and CVA or peripheral vascular disease. Next slide, please. So same here, what is written about the structure that I have already told. So we can move to next slide. So apolipoprotein is linked to, by a disulfide bond to an LDL particle that I have told, and producing a complete particle. That means when it is combined by disulfide bond with the LDL character is totally changed, and it becomes more atherosclerotic, and that we call apolipoprotein. That is the significance of this molecule. So next slide, please. So there is a genetic locus at chromosome 6, Q2627, from where apolipoprotein is synthesized. And we have seen there are two isoforms. One is large, another is small. Large isoform having repetitive single 2 type 2, it repeats many times, 40 to 60 times. So large molecule may give rise to a small molecular weight of lipoprotein A, and small isoform give rise to a large lipoprotein, large yes, large size give rise to small apolipoprotein, and that is LDL part. LDL that is means two isoform give rise to two. One is large isoform that give rise to small lipoprotein little a, and small one give rise to large lipoprotein little. That is the difference between these isoforms. Next slide, please. So same thing is written here. Low different numbers of exon sequence, including single 4 type 2 repeats. So that repeats many times in the apolipoprotein gene and correlates with the plasma lipoprotein levels, where large isoform give rise to low plasma lipoprotein little a, and vice versa. Next slide, please. So here we can see the single type 2, subtype 2, single type 4, and subtype 2, they repeats variable number. That means when it large molecular isoform, then it will give rise to low molecular weight lipoprotein little a, and when it is small, then it will give rise to large lipoprotein little a. That is the significance of this genetic isoform. Next slide, please. So here we can see it is generated from a plasmalogen gene, where lipoprotein single type 4 is repeated many times. That is the significance of this. Next slide, please. So same thing where we can see it many times it has been repeated, single type 4, type 2, single 4 type 2. So that is the molecular isoform that will give rise, different types of molecular isoform will be synthesized. Accordingly, lipoprotein A will be synthesized low molecular weight and high molecular weight. Next slide, please. So the structure of lipoprotein is similar to plasminogen. It is been inherited or it is due to evolution. It is generated from plasminogen gene and tissue plasminogen activator. So that's why now it competes with the plasminogen for its binding site, leading to reduced fibrinolysis, because plasminogen and tissue plasminogen activator, they break the clots. So next slide, please. So this slide shows the lipoprotein little a, it should be below 14 milligram, that is 35 millimole in normal person, and 14 to 30 is borderline risk, that is 50 to 75 millimole, and high risk 31 to 50, that is 75 to 125 millimole, a very high risk above 50, 125 mole and above. Okay, next slide, please. So lipoprotein little carries cholesterol, and this combines to contributes to atherosclerosis. In addition, lipoprotein transports more atherogenic, pro-inflammatory oxidized phospholipid. So once lipoprotein little is combined with the LDL, so every structure of LDL is oxidized and it becomes more atherogenic, more pro-inflammatory and thrombotic. Okay, next slide, please. So lipoprotein little concentration strongly and significantly correlated with the production rate, where there was no correlation with the lipoprotein little catabolism. Okay, next slide, please. So liver is the main organ where lipoprotein little is synthesized, and that has been confirmed by turnover studies in animal. Okay, next slide, please. Now, lipoprotein little, it is said that it cannot be modified by our diet, exercise, and conventional drug, statin group of drug. Now, if you see these different research comments, here we can find that some of the factors are there, or some of the biomolecule or is there, which can modify it can lower that lipoprotein little. So my intention was focusing this slide. Until an ideal drug is available, it can be used. So next slide, please. So here you can see alcohol. Alcohol, a little amount alcohol, 50 gram per day, can reduce up to 57%. So although we cannot prescribe alcohol because it may lead to addiction, but some of the medical products like Bear's tonic or some of the tonic, there we can get 15 ml. So if it is given for 3 times a day, so ultimately we may get the required dose. So this may reduce the lipoprotein little if it is very high. And we know the little amount of alcohol prevents heart attack, MI. So that may be the cause. Next slide, please. So anabolic steroid also, if lipoprotein little I is very high, we can prescribe for a short period to reduce the lipoprotein little value in the plasma, so that patient will be a bit lower risk group for developing SCVD. Next slide, please. Like that, estrogen progesterone that prevents female from during the menopausal period. After menopausal period, their estrogen progesterone level is lower. So during the fertile period, this estrogen and progesterone they prevent, and that's why heart attacks and CVA are very less below the average age of before menopause. So It can be given for a short period when lipoprotein literally is high after menopausal period. So my intention was until as ideal drug is available, we can give in combination or in a single just to reduce the risk because it is a slow process, atherosclerosis. And physician will tell up till now no drug. So even if you know the person is having high lipoprotein little a and his cholesterol LDL is lowered by statin group of drugs, but we cannot treat. In that case, we can use like that. That was my intention. Next slide, please. So lipoprotein promotes that I already told cholesterol deposition, inflammation, and blood clot formation. So it is pro-atherosclerotic, pro-thrombotic, pro-inflammatory. All characteristics are there in lipoprotein. Studies indicate that lipoprotein little levels increase the risk of ischemic stroke. That is already we know. So it is having three characteristics. All are written here. So next slide, please. So now we have a hope like that. New drugs are already going to be discovered. So when an ideal drug is available, like apart from inhibiting the genetic locus by siRNA ASO, but what I feel this last one, example of mubalapin, this drug actually will be a very good drug because it will prevent the LDL particle to be combined with the by disulfide bond with the apolipoprotein A. So apolipoprotein A will be synthesized by the genetic locus, but it will not be able to be connected by disulfide bond with LDL particle. So in that case, LDL particle will not be converted to a pro-atherosclerotic, pro-thrombotic, and pro-inflammatory. That is our lipoprotein little. So until this drug is available, we can use earlier what I have said. So what I feel this will be an ideal drug, and of course the final treatment will be gene therapy. That is in future if it is available. Until then, we will not disturb the genetic locus, but we can use this mubalapin if it is approved by FDA, and then we can use, and it will be very good drug. One way we will lower the LDL cholesterol by giving statin group of drug, and if lipoprotein little high, then we can use mubalapin also for a short period. So person apolipoprotein that means lipoprotein little and cholesterol, everything can be lowered and he will be risk free. That was my intention. So next slide, please. So from this description, it is clear that we have to estimate lipoprotein to each and every patient. Unless we estimate, we will not be able to know whether he is in a high risk group or low risk group. By estimating cholesterol and LDL, it is not enough. But nowadays, if you see, awareness regarding lipoprotein is very less. Even in my own hospital or own doctor, they are not writing. No laboratories estimating lipoprotein little a. Even I have presented in my college long time back, about 4 years back. But they say it is a risk factor. But if you go the new journal and new discovery, then we will know that it is the main which causes ASCVD and other atherosclerotic diseases like CBA and peripheral vascular diseases. So my intention is to that American Cardiologists Association should issue a order throughout the world so that everybody is aware about this and everybody should start estimating lipoprotein little a, so that and whatever modifying drugs are available we can use, and when ideal drug will be available, then in that case we will be able to control all ASCVD and other cardiovascular events. So that is my intention. So next slide, please. now this is my actual study. I earlier I have presented just to increase the sense or just to make awareness that lipoprotein literally estimation is very much essential. Although among the physician and among the treating doctor, even public, it is not so much. And nowhere lipoprotein literally is written unless in sophisticated center. So nobody is knowing how much the person is in a risk position. So with this idea, I estimated, of course, my study is very small. I spent my own money, and in my college, I estimated with few cases. And so next slide, please. So the type of study was case control study, location in the Department of Biochemistry and Medicine, and duration was about 2 years, April 2018 to March 2020, because I have to get fresh case. That's why. And participants 49 individual with acute stroke and 49 age and sex match control. Next slide, please. So inclusion criteria was patient with acute stroke and fresh, no old cases was taken, and age over 35 because as CVD is common above 35. No history of smoking and precision previous cardiovascular disease. That was the main inclusion criteria. Exclusion patient below the age of 35 because SCPD is not common below 35. MI all those. Patient with subarachnoid hemorrhage and having ischemic stroke because subarachnoid hemorrhage occurs mostly aneurysm and road traffic accident. So that is not directly related to atherosclerosis. That's why, and transient ischemic attack, any defect in the blood supply that may not be related. That's why those patients are not included. Patient one old patient on statin, that is also discarded. Although statin does not affect, but still I have excluded. Case and control were matched for age, sex, and with control selected from healthy relatives and hospital staff. Next slide, please. So data was collected as usual, a comprehensive history and laboratory findings and clinical data and were collected after obtaining the informed consent. Blood sample as usual is collected, and lipoprotein estimation was done by immunoturbidometric method because this is only available, and I collected this from our Goa. That is only chemicals that by reagent available. So with this immunoturbidometric, I just calculated this. And lipoprotein and other lipid profile like serum total cholesterol, triglyceride, LDL cholesterol were analyzed with the autoanalyzer. Next slide, please. So statistical tool analysis performed by SPSS with the help of a statistician. Statistical method, mean and standard deviation was calculated for all these parameter and used for representation. And P below when it is less than 0.05 it was significant. So next slide, please. Now here mean age group among the stroke patient was 61 and control 59, and male was 26 among the stroke patient, female 27, and among normal, and among the stroke patient, female 23 and female normal 22. And few cases were there who are having both hypertension and like 28, 17.28 cases and 26 your diabetic patient. So next slide, please. Now here we can see the lipoprotein little a value is 57.0.01 plus minus 15. So whatever case I got, all are having very high borderline risks. Even in the control, also somebody having moderate risk and somebody are having in a normal but almost all are aged patients. That's why I got a bit high among the normal also. But apparently, maybe they are normal. They are not having any hypertension, and so in course of time they may develop also. That may be the cause of high, a bit little high in the control also. Total cholesterol 214.7, plus minus 50. So it is almost little high, not very high. And among the control 165 and plus minus 35. Like that, LDL also a little high, 141.71, and among the control 103.9. And HDL cholesterol also not very low, 41.82, plus minus 67, and 52.92 among the controls. And triglyceride also a bit high, 222.67 plus 120. So my idea is that so much of lipoprotein little is high value is present, and almost all the present are in a very high risk group. So that was my finding. And for that only I estimated. Let me see what is the lipoprotein little value in my own population. Though it is said Asian people are having high. So now I can understand that lipoprotein little I should be estimated because it is more high in our population. So next slide, please. So BMR also 28.5 among the stroke patient a bit high, and controls 25. And fasting blood sugar, so those who are diabetic, they are high, but those who are normal, they are in the within normal range, 130 plus minus 25. And C-reactive protein inflammation a bit high in the stroke patient, and normal control 21, that is plus minus 0.08. So that is the other values. Okay, next slide, please. And ischemic stroke 35 and hemorrhagic stroke 14. It is from the record I filed, and that is percentage already mentioned here. And male patient 52.26 plus minus 12.6505, and female 61.76. So if you compare lipoprotein little value among the male and female are having a bit high because all the females are above, that is in the postmenopausal period. So that may be the cause why it is high in case of female. Next slide, please. So no significant difference in age and gender distribution between stroke patient and controls. High prevalence of hypertension and type 2 diabetes among the stroke patient. Mean lipoprotein level in stroke patient is above the 50. That means they are all are in the high risk, very high risk group. Significantly higher compared to the control, that is 17.75. Gender difference, I already told that in female it is high, suggesting the gender specific risk factor. That is maybe the estrogen progesterone that is low in during the menopausal period, and that may be the cause for high lipoprotein little in female person. So next slide, please. Higher level of triglyceride, LDL cholesterol, total cholesterol, and low levels of HDL cholesterol compared to controls. So higher, that may be high or low, but in my case, I got a little high. No significant link between high LDL to total cholesterol and raised LPA level, indicating the LPA may act independently in stroke. Some stroke patients had higher levels of CRP that indicates the chronic inflammation, fasting blood sugar, and BMI. These findings suggest that as increased stroke is a risk due to inflammation and metabolic abnormality. Elevated lipoprotein little level are associated with higher risk of cardiovascular and cerebrovascular events. That is from the literature, different literature. Notable correlation between lipoprotein little and severe adverse cardiovascular outcome. Okay, next slide, please. And this is the enzyme which is related with LDL and LPA. So in case of high um, lipoprotein little a, this is also increased, and that breaks phospholipid. That is the significance. So reduced HDL common in both ischemic and hemorrhagic stroke. The majority of the ischemic patient, 54.1, and nearly half of the hemorrhagic stroke, 46%, had lower HDL level. Next slide, please. So, in my conclusion, actually my actual idea was there just to increase the awareness about lipoprotein little, because it is not estimated. No doctor is prescribing unless in a specific center. So with this sense, I first study in AMI, then this is the next study in CBI cases. So study emphasizes the significance of impact of raised lipoprotein little in pathophysiology of stroke. Stroke patients had notably higher levels of lipoprotein little compared to controls, suggesting lipoprotein little as an independent risk factor for stroke. Data shows women with higher level of lipoprotein little level than men, indicating potential gender-specific risks. Decreased HDL cholesterol, increased level of total cholesterol, LDL cholesterol, and triglyceride. Finding underscore the importance of targeted uh, screening and treatment of strategy to manage lipoprotein little value and reduce the stroke. That means we should increase the awareness. Every doctor should write in the prescription for estimation of other lipid profile as well as the lipoprotein little. And if it is high, then we can give some modifier drugs unless or until ideal drug is available. But we have seen some of the molecule, even in Indian, some of the antioxidant, I have studied in the different literature, the ginkgo biloba, one of the antioxidant, it is widely used. And of course, there is a study or that I don't know, but it indicates that literature, ginkgo biloba reduces lipoprotein little. So like that, little amount of alcohol, little amount of other modifying factor we can use so long an ideal drug is available. And we can check after a few months after giving the drug whether it reduces the lipoprotein little. So that was my intention of this study. So thank you.
My topic is comparative characteristics of lifestyle, office, and ambulatory blood pressure among students from tropical Africa, India, and Russia. And I want to start from the statement of recent European Society of Hypertension guidelines. Hypertension is more prevalent, more severe, more risky for cardiovascular and kidney events, and more difficult to control in European and USA immigrants of heterogeneous African origin than in local population. This conclusion of European Society of Hypertension based on studies in which included mostly people, middle-aged or elderly people with hypertension. Less is known about young people from Africa and Asia. So goal of our study is to study the dependence of office and ambulatory blood pressure level in students with their ethnicity, in young people. Blood pressure level may depend not only of ethnicity, but also it may depends in African immigrants of their low salary, more bad living condition compared with native persons from Europe and United States. We exclude these differences in our study and mostly focused in ethnicity. Objectives: to check lifestyle and risk factors of arterial hypertension in African, Indian, and Russian students. To compare office
Hello,
blood
doctor.
pressure. Sorry?
Yeah, yeah. Could you please check with your slides? The slides are not moving here.
Check.
Yeah.
I do it. And now
Yeah, it's moving perfect.
objectives. Yes.
Yes, doctor. You shall proceed.
Mhm. To check lifestyle and risk factors of arterial hypertension in African, Indian, and Russian students. To compare office blood pressure in these groups of students. To reveal distinctive features of daily blood pressure in different ethnic groups. Inclusion criteria. We included 4 6-year students from medical institute named after Georgievsky. All of them are permanent residents of Russia, India, or Sub-Saharan Africa. All students gave their informed consent. Exclusion criteria of our study. Permanent arterial hypertension in students. Accompany cardiovascular, endocrine, chronic kidney, or nervous system disease. Material and methods. We included 110 students, 35 from Russia, 34 from tropical Africa, and 41 from India. These groups didn't differ by age. Average age was 22, 23 years old in all groups, and sex. All students answered to questions regarding risk factors of hypertension, diet, including salt intake, which can affect blood pressure level, physical activity level, family cardiovascular disease, and study load. And all African and Indian students were living in the same condition in the hostel, and they have the same level of study load. And Russian also has the same level of study load. We measured office blood pressure to all participants in the morning time, mostly in the break during classes. And ambulatory blood pressure monitoring, we also did to all patients. We checked 24 hours average systolic and diastolic blood pressure, daytime and nighttime systolic and diastolic blood pressure, daily indices, and blood pressure variability. Result. First of all, survey results. As I told, students from Africa and India lived in the hostel, and Russians less frequently lived in the hostel. But Russians had extra job more frequently compared with Africans and Indian students. But even in between students from Africa and India who lived in the same condition, we found some differences. So Indians are mostly vegetarians, more frequently compared with Russians and Africans. And they rare visited fast food compared with other groups of students. Time for homework also was different between Indian and African, and also Indian and Russian. Indians spent less time for homework. But these questions are according to lifestyle. And now we'll talk about main risk factors of hypertension. And main risk factors of hypertension, such as age, body mass index, alcohol intake, smoking, hypertension, and family cardiovascular disease, didn't show any intergroup differences. Sedentary lifestyle more commonly demonstrated Russian students, maybe because near the hostel there is a new sports center which regularly visited foreign students. Very important that majority of African students reported about salt overconsumption, and they add salt to food ready to eat, even statistically significantly more frequent than students from India. It can play a role in the development of hypertension in future because, as we know, Africans demonstrate higher salt sensitivity. So we have to pay attention to this habit of young Africans. Office blood pressure measurement. In all these three groups, we didn't find any differences in blood pressure, office blood pressure, systolic and diastolic blood pressure, and office heart rate. As you see, all values are in normal range between 100 and 120 millimeter mercury average for systolic and 60 and 80 for diastolic. Heart rate was between 70 and 75 in all groups. In 24-hour ambulatory blood pressure monitoring, we analyze separately 24-hour average blood pressure, daytime and nighttime blood pressure. Firstly, we'll talk about systolic blood pressure. In 24-hour, average blood pressure also was in normal range and didn't differ between Russian, African, and Indian. Daytime blood pressure also didn't differ, but at night, Africans shows more high average blood pressure level, around 114 millimeter mercury, and it was significantly higher than in Russians and Indians, which demonstrated average blood pressure 107 millimeter of mercury. Even more significant differences we found in diastolic blood pressure. Diastolic blood pressure in Africans was higher at in 24 hours at daytime and at nighttime. And at night, African demonstrated more high blood pressure than Indian students. Also, they had lower daily indexes of diastolic blood pressure compared with other group and more higher blood pressure variability compared with Russians. Now, we talk about mask hypertension. Mask hypertension refers to untreated patient in whom blood pressure is normal in the office, less than 140 over 90 millimeter mercury, but elevated when measured by ABPM. We make diagnosis of mask hypertension if 24 average blood pressure exceed 130 over 80 millimeter mercury, daytime exceed 135 over 85 millimeter mercury, and nighttime average more than 120 over 70 millimeter mercury. Mask hypertension is also important and common problem. According to different sources, its rate is around 10-20% in persons who visit hypertensive clinics. And patients with mask hypertension has more high risk of cardiovascular events than healthy persons. This risk is in some situation is even close to risk of patients with hypertension. So we analyzed frequency of mask hypertension in young persons from Africa, India, and Russia. At the daytime, ratio of mask hypertension didn't differ significantly, and it was from 10 to 20%. Africans and Russians shows 20% of mask hypertension and Indians 12%. At night time, Africans demonstrate very high level of mass hypertension. It was 41% of person. Indians and Russians shows lower level of mass hypertension. Indians 20% and Russians only 9%. In 24 average, also we see the tendency of more frequent mass hypertension in students from sub-Saharan Africa, but it doesn't reach statistically significant differences. Conclusion. Office blood pressure in senior students did not vary by ethnicity. Office blood pressure. With ABPM, no differences in blood pressure levels were found between Indian and Russian students. African students had higher blood pressure at night, including mass hypertension, than students from India or Russia. It should be emphasized that students from India and sub-Saharan Africa are living in the same hostel and has the same study loading. So these differences in blood pressure level may be hereditary, and it can be feature of African population with their tendency to hyperaldosteronism and so hypersensitivity. And as you remember, we found that majority of African students add salt to food ready to eat. So students from tropical Africa must strictly monitor salt intake. For students from tropical Africa, in addition to office blood pressure screening, we recommend getting night BP measurement. So we recommend ambulatory blood pressure monitoring to reveal BP elevation at night time and mass hypertension at this period of time. For students with mass hypertension, closer follow-up is recommended and healthy lifestyle, first of all, and decrease salt intake, especially for students from sub-Saharan Africa. Thank you for your attention.
And today we will be talking about role of anti-pro BNP in various clinical settings, looking beyond heart failure. Next slide, please. So anti-proBNP are the hormones. They are secreted both from atria as well as the ventricle, and they are normally secreted by myocardial stress, acute myocardial stress, be it for any reason, be it for heart failure, be it for any reasons. And in response to the stress, the hormones are secreted. Next, please. So it is ANP, atrial natriuretic peptide, and BNP, brain natriuretic peptide, released mainly from LV. And there is a half-life, mainly just 60 to 90 minutes for anti-proBNP, which is a commercially available product, what we see nowadays. Next slide, please. So this is the endogenesis of the PNP. It is pre-proBNP, which cleaves into proBNP, and then it is cleaved into anti-proBNP, which is a 76 moiety molecule, which is the inactive form, and the active one is the BNP, which is from 77 to 108 moiety. So conversion factor for BNP from picogram to picomole, you can see on the right hand side. And anti-proBNP, as you can see, it is stable up to 72 hours at room temperature. Next slide, please. So we all know that in case of stress, certain situations will cause the BP to rise. In such cases, ANP is secreted. ANP targets cells of the proximal convoluted tubule in the nephron of the kidney, which inhibits ANP, which causes which inhibits the retention of the sodium, causing natriuresis and the diuresis, thus causing lowering of the BP. It also causes muscle relaxation, causing lowering of the BP and hypertension. So this is in just the main action of natriuretic peptides in our body. So next slide, please. So you can see physiological effects. What are they? In cases of pressure or volume overload, BNP causes natriuresis or diuresis, as we already saw, by inhibiting sodium from the absorption in the proximal convoluted tubule. It also causes inhibition of the RAF, and it also causes inhibition of sympathetic nervous system in cases of high stress situations, also causing vasodilation, thus causing lowering of the blood pressure. Next slide, please. So these are the various physiological effects of the BNP. Now, because of these physiological effects, we can come into the clinical applications of the heart failure. So, main, and we all know application of heart failure of NT-proBNP is heart failure in the detection of the heart failure. And not only it causes the diagnosis, but it also has a prognostic effect and increasing values signifying increasing increasing severity of the heart failure. Next slide, please. So you can already see from NYHA, moving from NYHA 1 to 4, there's an increasing level of NT-proBNP. And based on various study reports as published in circulation, it's even with a combination of judgment, physical examination, X-ray, and ECG, NT-proBNP was found to be single best predictor for heart failure even. Next slide, please. So BNP values, there are various values which are determined based on the age and sex. We will be seeing in the subsequent slide. And it's a valuable addition to standard clinical examination and assessment for identification and more of a exclusion value, ruling out value rather than ruling in value for the heart failure, as we will be seeing in the subsequent slides. Next slide, please. So it is also predictor of cardiovascular events, future cardiovascular. Next, you can move future cardiovascular events and death. So we can see the p values of p values of NT-proBNP in case of first cardiovascular event and death. It is statistically significant when compared to placebo. And for all outcomes, the hazard ratio were adjusted for age, sex, or presence or absence of hypertension, ratio of total to high density lipoprotein, smoking status, presence or absence of diabetes mellitus, body mass index, and serum creatinine levels. Next slide, please. So you can see in cases of heart failure and first uh, cardiovascular event, the elevated value of NT-proBNP was statistically significant. So how well does BNP predict death and cardiovascular event in patients with heart failure? It's a systemic review, and 19 studies used a BNP to estimate the relative risk of death or cardiovascular event. And what does this study add? This study add that BNP is a strong prognostic indicator for patients with heart failure at all stages of disease and showing to be a better predictor of survival than many of the traditional prognostic indicators, including NYHA class, including the clinical judgment, including ECG, X-ray. And the relative risk of death increased by about 35% for each 100 picogram per ml increase in the BNP, as we already alluded in the previous slide. Next slide, please. So this, I was talking about the various rule out zone, that if the NT-proBNP is less than 300 in the age group of 50 to 75, we can virtually rule out heart failure. Similarly, if the NT-proBNP is more than 900 in the age bracket of 50 to 75, we can virtually rule in heart failure. Next slide, please. Similarly, the values are different for more than 75 years of age. Rule out is less than 300 and rule in more than 1800. Now, there are various gray zones. We saw that between 300 to 450 and between 300 to 1800 in cases of more than 75 years. These are the conditions that can be mimicked by various other conditions and that may spuriously cause falsely elevated NT-proBNP. And some such conditions are, it can be acute coronary syndrome or atrial fibrillation, anemia, aortic stenosis, pulmonary embolism, sepsis. So these are various conditions that can mimic situations that can be in the gray zone. And gray zone is between 300 to 900 in cases of 50 to 75 years of age. and in up to 1800 in cases more than 15 years of age. Mind you, certain drugs like even ARNIs, even SGLT2 inhibitors, what we are using in heart failure, they can cause falsely low levels of anti-proBNP. And in other cases, drugs like beta blockers, digoxin, aspirin may falsely cause elevated anti-proBNP. These are very important in our day-to-day practice. Next slide, please. And keeping some such situations are very helpful for borderline patients where they may be having coexisting comorbidities. Now, these are the conditions. Apart from cardiac, these are various other extra systemic conditions that can cause elevated NT-proBNP. Some such are ischemic stroke. Then there can be toxins like cancer chemotherapy. Then there can be pulmonary diseases like pulmonary hypertension, pulmonary embolism, infection. Then there can be critical illnesses like sepsis, burns, and there can be other situations like renal insufficiency, anemia, cirrhosis, hypertension, and others. Next slide, please. So you should remember, I already talked about the cardiac conditions. They are high output rate, aortic stenosis, pulmonary embolism, various conditions, pulmonary hypertension that can cause falsely elevated NT-proBNP. Now, on the reverse side, we have conditions where there may be falsely lowering of the NT-proBNP rather than elevations. And what are they? They can be flash pulmonary edema, not just pulmonary embolism or long-standing, but it is flash pulmonary edema, mitral stenosis, burnt out cardiomyopathy, because there is no other tissue left which can cause production of the NT-proBNP. Now, pericardial constriction, because there is we will be seeing in the subsequent slide. This is one of the points where pericardial constriction, constrictive pericarditis can be differentiated from restrictive cardiomyopathy. Next slide, please. Other conditions are acute MR and cardiac tamponade. So where we stand today, next slide, where in the role of NT-proBNP in the new guidelines. So we all know now NT-proBNP more than 125, we should start thinking in terms of heart failure. Next line investigations are getting echocardiography apart from ECG and doing clinical maneuver. And echo will reveal whether we are into which phenotype, whether it is HFrEF, HFmrEF, or HFpEF. Depending on the EF, we can divide. More than 40 will be more than 50, sorry, will be HFpEF. 41 to 49 will be MREF, and less than 40 will be HFrEF. Next slide, please. So we will be seeing in the subsequent slide that NT-proBNP class 1B, it stands tall ahead apart from ECG, echo, X-ray, and our routine blood tests, including CBC, electrolyte, stands ahead of all these tests, and it's a class 1B indication for carrying out in all patients suspected heart failure. Next one. So apart from history science, we should have ECG, SpO2, echo, initial blood test, which includes CBC, CRP. We can have lung ultrasound, and so that's a separate different topic, determining the B lines. And then we have, after all these, we can carry out NT-proBNP, which according to the age has already been satisfied according in the previous slide, and more than 300 in age group of 50 to 74, and more than 1800 in age group of 74 is a definite indication, because we all know that age does an effect on the NT-proBNP levels. It has every decade of life adds to NT-proBNP. Next one. So that is why the newer guidelines are stating on the age. Now there's a very beautiful chart. It's a bit busy, but if you'll see that any of the patient having shortness of the breath, we should suspect of heart failure, and we can straight away move on to the NT-proBNP. And if it is more than 450 in cases of less than 50 years, in cases of 50, 75, it is more than 900, then heart failure is very likely, and we can start away with therapy. In gray zone, we already talked about the various conditions which can cause alteration of these values. And less than 100, we all know the heart failure is very unlikely. Then it is at the admission, and then at the time of the discharge, we should have a follow-up NT-proBNP, and if it is more than 30% decline in the value, then we should think that it is having a good prognosis, and accordingly, if it is less than 30% decline of the initial value, then the GDMT should be further optimized. Next slide. So coming on, we can have according to the stages of the heart failure, NT-proBNP, it's a class 1 recommendation in stages C and D heart failure. Apart from which now the newer algorithm is saying apart from NT-proBNP, we should also measure ST2 and troponins. And if all three are positive, ST2 more than 35 and cardiac troponin positive, then it indicates a poorer prognosis at the time of the admission. Next slide, please. So clinical applications, we all know necessitide. It's a recombinant BNP because of the physiological effects already explained in the previous slide. It has been very useful molecules in cases of heart failure because it facilitates natriuresis, it causes diuresis, it inhibits RAS system, it causes increase in the output of the cardiac output. Next slide. So how we are seeing its NT-proBNP is evolving not just from diagnosis, not just proving to prognosis, but also is having a therapeutic effect. So this is the slide of what I was talking, cardiac troponin, natriuretic peptides, and ST2. This good triad for all the patients admitted for the heart failure at the facility uh, and finances permit, then we should have evaluation of all three. And if troponin are persistent elevated, that indicates poorer prognosis. If NT-proBNP, the values doesn't decline at the time of discharge to less than 30%, it indicates a poorer prognosis. And if ST2 is more than 15.5% from the time of discharge, if it is 65 at the baseline, if it is decreases less than 15% at the time of discharge, indicates a poorer prognosis. There's a J shape and the U shape. J shape, it's a declining process. U shape, it is a climbing up again. That indicates a high risk patient. Next patient. So this is the latest from the coming up from the guidelines. This is the latest triad. Next slide, please. So identifying congestion, next one. So how can we identify congestion based on the markers? So apart from natriuretic peptide, we are having bioadrenomedulin and CA125. The advantage of CA125 is that it's longer half-life. And bioadrenomedulin, it is having a short half-life and it's having dynamic assessment of tissue congestion. May be useful with serial assessment. And next slide, please. Main use is in as of now, its main use is in studies. It has not yet come into vogue into the clinical practice. So now we are in various markers. We already studied congestion can be identified on natriuretic peptide, bioadrenomedulin, CA125. Prognostic markers apart from natriuretic peptide, we have ST2 and cardiac troponins. And for diagnosis, of course, we have natriuretic peptides and proadrenopeptins. So now you can see how beautifully natriuretic peptide is fitting into everything, right from diagnosis to prognosis to congestion. Next one. And we have various other molecules for prognosis. So it's a strong HF, it's a safety, tolerability, and efficacy up titration of guideline-directed medical therapy, and how it indicated that very strong use of all the guideline-directed medical therapy, and that too with a maximum tolerated dose causes rapid down titration of the NT-proBNP, and then it's rapid down titration of NT-proBNP, and we can see how the NT-proBNP cause a fall in the value right from 3,200 to 1,300, and in the usual care group it was from 3,159 only to 1,729. So this fall was statistically significant, and based on the markers, we can what we were achieving in 8 weeks, we can achieve in less than the usual period. Next slide. So this is the importance of the markers. So key findings, this is from Emperor reduced trial. We see that when they were up-titrated to the maximum tolerated dose and NT-proBNP was measured, we can see the empagliflozin, as we already told that empagliflozin, all the SGLT2 inhibitor causes reduction in the NT-proBNP and thus favoring, and now it is one of the four main pillars of the heart failure. And it's a consistent relative benefits with dapagliflozin irrespective of the NT-proBNP. So this is one of the key features that there's a greater benefit of SGLT2 inhibitors when the patient is having higher NT-proBNP and the benefits further reduced when the NT-proBNP levels got down-titrated. But in cases of empagliflozin, it reduced event rate similarly across all the NT-proBNP quartiles, whatever be the baseline values. Next slide, please. So this is one of my own original research article published in collaboration with of my guides, the NT-proBNP levels in congestive cardiac failure. And this was a large study conducted in central India. Next slide, please. And where we found that NT-proBNP, next one, correlated very well with ECG, echo, and it didn't correlated much with age, gender. Next one, age, gender, or BMI. Although we know that obesity does have obese patient does have a lower NT-proBNP level than the rest of the population. Age, age and pregnancy, it also causes significant elevation in cases of pregnant patients. Next slide. So it's a predictor of cardiovascular event. Moving from heart failure, it's a predictor for heart failure event. NT-proBNP above the 80th percentile, it is an indicator for increase in the mortality for the next 5 years. And next slide. It has a higher significant risk for the first major cardiovascular event. This is from Framingham study where 3,346 patients, mean age of 59 years, and were followed up for 5 years, and we can see at 5 years, hello, yes, at 5 years, 119 patients died and 79 patients had first cardiovascular event. Hello.
Yes, doctor.
Next one.
Audible. Yeah.
Yes, next one. So serum ANP and BNP correlated with LV dysfunction. So we all know plasma concentration of both hormones are increased in patients with whether be it asymptomatic or symptomatic left ventricular dysfunction. So further the lowering of EF, there will be increase in the ANP and BNP concentrations. Next slide, please. So apart from diagnosis, therapeutics, we are moving on to prognosis, not just in heart failure, but also in ACS. Increased mortality has been found to be in patients who are having elevated NT-proBNP. Next one. So acute coronary syndrome, we all know that both markers, troponins and CRP, they have a highly predictive for adverse outcome independent of other biomarkers. Similarly, NT-proBNP and BNP were predicted for mortality in heart failure after an ACS, but not for recurrent ischemic events. So this is the point to be given importance, that they are predicted for mortality in heart failure after an ACS, but not recurrent ischemic events. Next slide, please. So now, moving from heart failure ACS in stable angina, they are having prognostic value. Around 1,000 patients with plasma BNP were prospectively followed up for mean of 2.5 years. And the patients with highest quartile for NT-proBNP were compared with lowest quartile of NT-proBNP. And it was found that higher NT-proBNP was associated with worse prognosis in cases of stable in case of stable angina. Also, 288 patients had died at presentation at higher NT-proBNP at presentation than at discharge. Next slide. So again, coming on to arrhythmias, moving on to various conditions, now coming on to arrhythmias. Various, be it atrial fibrillation, ventricular tachycardia, or low EF, they all are associated with higher NT-proBNP values. And based on this, levels of BNP are significantly elevated in Takotsubo cardiomyopathy, and we all know how problematic it can be in our day-to-day practice. Charcot-Sico cardiomyopathy mimicking ACS and other events. So the ratio of BNP to cardiac troponins can be very useful in determining patients, and lower, next slide please. Lower values of we all know that higher values will be there in cases of Takotsubo cardiomyopathy, whereas in ACS event, there will be a lower ratio. So we can see that in cases of LVF change, sarcopseudomyocarditis has within 2 to 4 weeks they have a very good improvement in EF, whereas in ACS the EF may show relapsing and remitting pattern. So this is one of the study where the ratio of NT-proBNP to troponins were helped to differentiate sarcopseudocardiomyopathy with AMI, because in cases of sarcopseudocardiomyopathy, the ratio will be higher, more than 7.5, whereas in ACS it will be less than 7.5. Sorry for the printing, this is an error. Next slide, please. But in sarcopseudocardiomyopathy, it will be higher. Now, moving on to valvular heart disease, we all know the value of NT-proBNP in aortic stenosis and all the aortic stenosis. So, both NT-proBNP and BNP are related to disease severity, functional status, and disease progression, with a decline of elevated values after a successful replacement. Next slide, please. So, it also provides prognostic information for unfavorable event. So we all know severe aortic stenosis, it causes increase in afterload, increase in LA pressure, increase in wall tension, causing elevation in the NT-proBNP. So not just diagnosis, but a higher NT-proBNP are associated with a poorer prognosis and a accelerated progression to the disease severity. And also later on, they may develop subclinical LV dysfunction. Worst post-procedure outcomes have been found to be in patients who are having baseline elevated NT-proBNP. Next slide, please. So it is also helpful in differentiating true stenosis from those with pseudo-stenosis. So after classification using dopamine stress echocardiography, patients with true AS compared with those pseudo-stenosis had a significantly higher BNP values. Also, 1 year survival significantly lower in patients with plasma BNP more than 550. So we can see next slide. We can see how useful this marker is across the continuum of the various cardiac condition. Next slide, please. So, study by Kovac, Kant, and others in 2023 showed that BNP is a prognostic marker in asymptomatic patient with severe AS, and values above 3 times normal indicate intervention. NT-proBNP also showed promise for detecting symptom onset and AS severity, but further studies are needed to validate their use. NT-proBNP combined with other biomarkers and imaging modalities could enhance diagnostic accuracy and provide a comprehensive assessment of cardiac function and structure, especially in asymptomatic AS patients, thus guiding therapeutic management. Next slide, please. So summary for AS is, it is guideline approved. NT-proBNP serves as a prognostic marker. It's a promising marker to detect the severity and progression of AS. An early detection would help to see the progression of AS at an early stage. Next slide, please. So we saw how NT-proBNP moved not just from heart failure, it moved from across the continuum of CAD, ACS, aortic stenosis, and moving on, next slide. Moving on, we have various conditions of constricted pericarditis. So wall stretch is an increase in restrictive cardiomyopathy, but minimize in constricted pericarditis because of the thickened pericardium. And this difference was taken into account where there were 5 patients for restricted cardiomyopathy, all having elevated NT-proBNP from the baseline, whereas other 6 patients that had NT-proBNP having lower than the normal baseline values. Next slide. So this is one of the many of the applications of NT-proBNP. Now moving on to pulmonary hypertension, plasma BNP are elevated in patients with primary or secondary pulmonary hypertension. Next slide, please. Sepsis, again, we saw that amongst 249 consecutive patients, 24 were diagnosed with sepsis and 51 with decompensated heart failure. So observational series from a single center indicated that patients having a diagnosis with sepsis are likely to have elevated NT-proBNP. Patients with decompensated heart failure has a significantly higher pulmonary arterial wedge pressure and a lower cardiac mean index, and having a higher NT-proBNP at presentation. Next slide, please. Clinical application, postmortem, it is also serving as a postmortem biomarker to evaluate cardiac function. Forensic pathologists only focus on the diagnostic value of NT-proBNP. Diagnosis of heart failure, evaluation of cardiac dysfunction, and autopsy is based predominantly on morphological and pathological findings. Visible morphological changes of the myocardial structure are caused by acute heart disease, such as acute myocardial ischemic injury, are quite limited. Compared with morphological indicators, functional indicators of biomarkers such as NT-proBNP could reflect the cardiac function and pathophysiological process during death. Because morphological changes may take time, and such functional indicators like NT-proBNP are suddenly changed, and this may help our forensic pathologists and forensic scientists to determine the etiology of death, sudden cardiac death. Next slide, please. So post-operative complications, the patients having elevated NT-proBNP at the baseline are known to have increase in the post-operative complications and increased risk of adverse cardiovascular event at 30 days. So it is suggested nowadays, even in the newer guidelines coming up from the ACC for pre-operative non-cardiac surgery, for pre-operative checkup, we should have a baseline NT-proBNP in those having elevated cardiac risk. Next slide. Next slide, please. So moving on to one of the last slides, previous CKD, where we all know that renal failure is one of the previous slides. Renal failure is one of the markers for elevated NT-proBNP. And previous slide, can you show previous? Hello. We all know with the role of the exercise that for the more the exercise you do, there is a release of the natriuretic peptide, and which causes lowering of the blood pressure, which causes vasodilation, thus causing decrease in the cardiac output. It also causes diuresis, natriuresis, and inhibition of the RAS system. And there is mitochondrial increase in the respiration and increase in fatty acid oxidation. Next slide, please. It also helps in lipolysis and increase in the mitochondrial biogenesis. So we have studied the role of NT-proBNP. Now it is not just restricted to heart failure, but various conditions like post-operative complications, to even differentiating it from constrictive to restrictive cardiomyopathy, in determining the poorer prognosis of the sepsis patient, in determining the prognosis and development of the re-ischemic events in ACS patient. In aortic stenosis, we saw how it can not just protect the diagnosis, but also how fast they will be progressing onto significant aortic stenosis requiring TAVR or SAVR, and how such patients may benefit from early surgery. And also for patients with coronary artery disease, it not only just predicted the prognosis, but along when combined with troponins and ST2 and other markers, it is very useful in updating which patients need to be carefully and further observed at 30 days. Next slide, please. So now we have various conditions. So this is the future that NT-proBNP may be selected prevention of cardiac event in a population of diabetic patients without a history of cardiac disease. So this is the ongoing European study, and accelerated in such patients who are having elevated NT-proBNP at the presentation, whether they are not having any of the cardiac event, we can have rapid up titration of RAS and beta blocker to maximum tolerated dose for effective and safe intervention for primary prevention of cardiac event. Not just secondary, but now it is moving on to primary prevention. Next slide, please. So in a nutshell, these are the points I would like to take you all to the home messages that natriuretic peptide have made the diagnosis of heart failure more accurate and accessible, besides enabling prognostication, risk stratification, and screening of at-risk population. More recently, their monitoring has facilitated further optimized management for heart failure patients. And we already alluded in the previous slide, apart from heart failure, even with valvular condition, constrictive versus restrictive cardiomyopathy, in cases of even helping forensic pathologists to determine the cause of the heart failure, and in ACS patients. Although there are established use of natriuretic peptides used in special populations such as patients with obesity and HFpEF need to be further examined. Next slide, please. So thank you very much. Thank you And I would like to extend my heartfelt gratitude towards this third Cardiovascular Research Society, rightly telecast from Dubai and USA, for giving me this opportunity to express my view. Thank you, all the management staff, for giving me this opportunity. And namaste from Dr. Sriram Agrawal from India. Thank you. I would be happy if any questions.
Thank you so much, Dr. Sriram.
And some work that we have done in collaboration with Sri Sathya Sai University is what is going to be it will be presented during the talk. I'm basically a tech person. However, in my work over the last 30 years in this organization, surrounded by clinicians, we have always been questioned about. There's a lot of data that is getting generated around this, but what does it use? Kind of what I mean is, we are proud to say that we have been having a health information system, and we have been using that for, well, probably we are one of the early adopters of health IT. But just going over from what was recorded in paper, things were getting recorded. Clinical information is being recorded in the system. So if there's a lot of data available there, what can we do about it? Because if you talk about the pyramid of data, it starts with data. You extract some relevant information. Possibly you will look at generating appropriate, deriving knowledge out of it. But the thing is about gaining insights. So is there a possibility to do that? Is what our exploratory work, and definitely that did lead us to some interesting findings. So this healthcare challenges is something not new to the audience. This is something always we talk about. We have had COVID-19. So the impact of the diseases on the entire world is well known. Coming to even talking about a country like India, we have had our doctor to patient ratio, which is expected to be 1 versus 1,000. As per WHO recommendation, we have had a 1 versus 834 patients. Of course, over the last 10 years, it's glad to know that there is an 82% raise in the number of medical colleges, and so much so 112% rise in the medical seats. So things are improving, but nevertheless, is there a way to intervene earlier and help the patient is something which is always every clinician's dream. Of course, this became a basis and we proceeded from here. Talking about informatics system, it's about developing appropriate system to capture relevant clinical information, process it, and then use it. So what is the purpose? What is the underlying uh, uh, the fundamental behind all of this? Obviously, we are looking at improving the efficiencies of the management of the operations and the involved in the organization. Obviously, if we are able to have better documentation and presentation of diagnosis and the treatment, it would aid in obviously tailoring that treatment to patient specific treatments in the clinics that we see. Of course, over time, if you are able to generate good data, we can look at whether we can generate insights to enhance the cohort treatment as a whole. This somewhere, if you look at the uh, SDG goals, SDG, as you would all know, Sustainable Development Goals, the third one talks about good health and well-being. They have 13 targets, and one of the very clearly specified outcome target is reducing mortality from non-communicable diseases. So here we are talking about the cardiovascular diseases, and of course it's a non-communicable disease. Is there a way we can intervene and do things? And they also have prescribed a means that can we work on improving early warning systems so that we can intervene earlier and help the patients. Example, this is mortality rate attributed to cardiovascular disease, cancer or diabetes or chronic respiratory disease. If there is a way to intervene earlier, is something we always looked at. So this is precisely was our goal, looking at early warning system where the clue is taken from there, and that's what forms the basis of predictive analytics in healthcare. What we mean by predictive analytics, okay, I can go on giving a lot of description of what predictive analytics exactly it is. All clinicians and all the researchers would have always, in their work, would have used simplistic statistics to look at your p-values and things like that, where you want to, when there is a finding, you want to see how reliable your finding is. And of course, and there's a one inherent assumption that also happens is with all the tools that we have is an assumption of linearity. That is, the features and the outcome, or the dependent and independent variables are kind of, you have a linear relationship, when in reality they aren't. So how do we go about doing this? That's where data driven models or data driven tools are available, which falls into the domain of artificial intelligence, more so in the domain of machine learning, deep learning, and all those tools that are available as of date. So predictive analytics in healthcare in general could be used to automate routine tasks, or very specifically meet out a patient and maybe be able to assist him. Or can we, in a very clinical setting, can we look at focused patient care and improve their outcomes? So this was our intent, and we have done some work. This is just a summary of our work in terms of, we have looked at looking at patients who have undergone valve replacements. For when it comes to dosage INR management, we were looking at whether be the hospital or even after patient discharge, could we look at dosage calculators which recommends the required anticoagulant that needs to be prescribed, and can it even predict what would be the INR value post the medication the next day or next 2 days or so. So that's one example. The second being the screening cardiogenic brain abscess in TOF patients. TOF, yeah, the inherent the condition that the patient is diagnosed with. Obviously, they are more prone to brain abscesses than anybody else. So can we expedite the diagnosis in a way by using predictive analytics? That's the second one. Third, in the neurosurgical domain, we had looked at preventing recurrent lumbar disc herniation, and the last being assessing the mitral valvotomy, balloon valvotomy's outcome in the mitral stenosis patient, and is there a way to improve? So today, I'll be picking up two of these and then talking about in the next few minutes that is given to me. So the objective was very clear. Can we have predictive model to make useful predictions? Can it help the clinicians improve their prognosis and treatment planning? What is the basis? If you have to do it, the simplest is you have your attributes or the features, and you have an outcome, whether it is whether the patient to be chosen for a surgery, or can we diagnose or a presence of a certain condition or so. So what are those features which actually contribute to this outcome? And which are the ones which are most predictive, or which indicates these patients having these features are more prone to having the disease, or better, or prone to have a better outcome? And are there any interplay between these attributes which are actually not so inherent, not so apparent? Can we look at those, and then can predictive analytics help us in finding out those interrelationship and help us take it to the next step? So this was our prior standard description of our problem statement, and we launched ourselves from here. So invariably, it's all has been a retrospective study. Obviously, we have identified data, and we have gone with the stroke guidelines, and this is the study protocol. Okay, coming to the first one, cardiogenic brain abscess or cerebral brain abscess from the for the patients who are already predisposed with tetralogy fallow. Tetralogy fallow is something I don't have to possibly explain to this audience, but nevertheless, you have four conditions. Obviously, you have right to left shunt, because of which, and possibly because of which you have the kind of in a simplistic way, the blood going back, the impure blood kind of the going back to the brain, and becomes a active place or active bed for infection, which definitely could lead to brain abscess. So if you are looking at brain abscesses, obviously we have in kind of in the TOF condition, and with that being a congenital condition, in a lot of deaths, mortality is attributed to brain abscess, undetected brain abscess, so much so. So that was the problem that we had. So this being the major cause of CHDs, kind of that is TOF being one of the major disease that is observed in the condition observed in the CHD, and BA being one of the commonest cause. Untreated TOF obviously increases the risk for BA brain abscess. So kind of this may be more helpful if in resource restricted settings, possibly the only way currently to diagnose is USET, which marks the presence of brain abscess. But is there any other way of approaching it? Because not everybody may have access to a CT imaging setup nearby, particularly places which in rural and semi-urban areas, not everybody may have access. Is there a way to expedite the diagnosis to make it better? Because in general, a patient having non-specific symptoms, which possibly are more similar to TOF and BA, may have similar symptoms that are being presented at a clinic. So we were looking at what are those markers which can predict the occurrence of BA and TOF and help them in early treatment. So we took around 125 patients, and all these kind of the patients have undergone. You had the protocol very clearly. We talked about the two groups that we split into, and this is the male versus female ratio is 22 versus 8, and kind of all the data preparation activity had been taken up. So these are the clinical parameters that were considered: the BMI, BSA, presence of cyanosis, the patient having spells, dyspnea, age-adjusted heart rate, percentile oxygen saturation in labs, obviously white cell count, neutrophil lymphocyte ratio, platelet count, ESR, bilirubin levels, and coagulation profile. Over and above that, the chest pulmonary oligemia was taken, and the echo parameters such as PA index, pulmonary stenosis, that is whether there is a branch confluence or there or not, and how the pulmonary valve stenosis, and the type of VSDs. Obviously, we had put together a machine learning framework, starting with classification algorithms and more possibly advanced algorithms such as even combined association pattern analysis. So it's a kind of, though it is seen as a black box, but nevertheless a very, very helpful framework that we have put together. We call it the CARS, combined association rule mining with SHAP analysis. That's a framework that we have designed for it. And when we ran across various machine learning models, we found some of the models which is highlighted here, the last ones being random forest and extreme gradient boosting. These are black box algorithms that the off-the-shelf algorithms that are available. We got a very good results. As you see, you are able to see the AUC curve as well as and the confusion matrix. So ultimately, to look at even to see whether how much confidence can we or that we can place on this machine learning algorithm, we have a conformal calibration curve which is preferred to kind of give you a kind of a p-value where it says a test error rate here of 0.047, which means that with 95% kind of confidence, I've been able to say the results obtained from the study are good. What does it lead to? It leads to an very explainable a graphic that is presented here, which very clearly indicates it's called a SHAP graph, which actually presents the influential parameters in the top, the most influential on the top and the least influential in the bottom. And you see blue and red dots, where the red ones mean that the pink ones mean that they are more influential, and the blue ones say they're less influential, or rather it says the less number of blue indicates the less number of data points attribute to this outcome, and pink talks about more number of attribute or more number of data points attribute or more number of patients attribute to this particular outcome in the given data set that we're talking about. So if you were to look at it from the left and to the right, to the left it means that it gives a negative connotation. That is, it says if there is no second one, if you were to look at, there is no branch confluence, where the pink is higher means it is on to the left. So there is no branch confluence contribute higher to the brain abscess. If there is a branch confluence, it is not much, but absence of branch confluence obviously adds on to the already existing, the interpretation would be it would add on to the already existing right to left chain, and it makes it more difficult of allowing the phagocytes to travel to the brain to result in brain abscess. Okay. So that's what it is. The implication would be the bacteria bypass obviously overtakes the natural phagocytic component of the pulmonary circulation and enters the cerebral circulation. So the higher value of neutrophil lymphocyte ratio would mean there is an infection, and no branch conflict also adds to the infection. And again, BT3, that is your BT talks about increase in blood viscosity, and obviously focal area of brain parenchyma ischemia, which is obviously led for infection. So if we were to translate, okay, this is what is a finding, what does it mean in a realistic scenario? If we have obtained we have obtained this list of features that are most predictive, and we have very clear understanding of those parameters and their values, how they contribute to the kind of inherent condition that we are discussing about. It can be translated in the real life scenario to be something like in a setting or PHA or primary healthcare or a community healthcare center. If the patient is having cyanosis, obviously you look out for any underlying heart condition that is already existing. Looking at your cardiac parameters, you would be able to know that top condition exists and check for the blood confluence. If you find this, do a simple blood work for bleeding time, hematocrit, and NL ratio. And if we find NL ratio to be higher, BT to be higher, and all of these would automatically could indicate you refer to a patient to a higher diagnostic center for CT to confirm your diagnosis. If these are not at this not there, then not every patient need to go for a CT, because how it actually translates would be the amount that a patient needs to spend. If you ask to this, I have given it in the kind of a standardized rates that is used in India, which a CT brain, according to CGHS rate, is 1,600. You don't have every patient to looking at the condition. You don't have to make them all undergo the CT brain. While you do the preliminary checkup, which could cost you just 157 rupees in total, looking at the lab work, obviously, if the patient is having an already inherent heart condition, you would have the echo parameters already presented to you, and only if they are kind of above your normal values, then it is an indication for definitely for a patient to undergo a CT brain to confirm your diagnosis. So this is a simplistic translation of ML techniques being used to arrive at a protocol, which possibly could be used as a kind of a methodology to expedite diagnosis, particularly more so in remote areas where the medical care and the facilities are not readily available. This is published in this particular journal. And going further, the second study, which is a PTMC, percutaneous transluminal mitral commissurotomy outcome in patient with mitral stenosis. This is a very clear condition that we are talking about. So much so, if you are looking at young adults and children in developing countries, is the current RF burden, that is RHD burden, is around it's huge, and there are almost 0.23 million fatalities each year. That's what the statistic says. And even looking at more specifically in India, we have found that mitral stenosis in India is estimated around 3 million cases, which is possibly highest in the world. And this accounts to 30 to 40% of valvular heart diseases in India. So what is this the readily available methodology to treat a mitral stenosis? Obviously, after looking at the parameters, if we go by the Apscal's echocardiographic score, which is the Wilkins score, which is based on those 4 parameters, you would, if it is less than or equal to 8, obviously he seems to be a candidate for PTMC. Otherwise, it is observed, and if it is much worse or higher side, more than 12 or so, he is referred for surgery, open heart surgery. But can we look at, because if you, as you would know, Wilkins score is a qualitative score. Here is an attempt to use ML techniques to see if we can present possibly or try and work towards an alternative mechanism than Wilkins. It's just a humble attempt from our end. So we were looking at all the criteria that is already given in the literature, and to that, obviously, even the success of PTMC cannot be fully attributed to Wilkins score alone. The reason being, even the patients having Wilkins score less than 8 can still have a bad MR, or could be have an increased RBSP or LA pressure. So So the intent was to look at not just look at Wilkins score, to look at comprehensive set of parameters and look at how your post-procedural mitral valve area is, with the kind of the quality of MR, or what is the thing of MR is, and look at RBSP fall or LA pressure fall. So all we were looking at, take all these four criteria, four clinical metrics as criteria for deciding the success of PTMC. So in the technology terms, or in the machine learning terms, it translates into a multi-label classification problem. We have had data of over 9,000 patients in our center between 2007 to 19, with, were moderate to severe MS. So we have taken them to work with it. This is the kind of data that we have used, and the codification and the preparation of data that we had done. We had just did not stop with the individual criteria, which is part of Wilkins. We looked at the LVRV function, the MR, AR, AS, TR, all the all the other valve morphologies as well. Initial MVA, looking at ALC, PMC, and the nodules as well, and rhythm, and whether the patient has had prior surgery or procedure or not.
Hello,
So,
Dr. Subramanian. Yeah, sorry for the interrupt. You have
yes,
left for 2 minutes for your presentation.
I have 2 minutes to conclude.
Yeah.
Yes, thank you. It should get over. Thank you.
Okay, doctor.
So this is our kind of translating this into the criteria. We have come up with added to the existing framework. We were trying to look at the weights. That's what it finally translated into. What is the weight of each of these parameters? How much mitral valve area, MR, LA, or RVSP contributes to our success? So we found a mechanism to arrive at the weights, and the linear combination of weights were used to call it as a procedure as a success. Of course, the same. Was the kind of worthy of contribution from our end, and subsequently the same framework, the CAST framework that we have created earlier, was run through, and obviously this was the interpretation of the sharp graphic, and you have the RVSP topping the chart, and of course mitral valve area. You may observe in the top 7 criteria, you will have calcium and mobility topping, and of course SVF and thickness comes lower than these two. So first 5, if you were to consider, calcium and mobility from the Wilkins score are part of it. So again, looking at a protocol, it will translated into, if you look at patients who are having RVSP less than 50 mmHg, calcium score 2, mobility score 2, and normal sinus rhythm patients, and with no prior procedure and mild TR, they definitely would have a successful MVR, because that was a finding. So kind of it takes into consideration 2 of the Wilkins score parameters, but nevertheless it adds the other parameters as well as the features which would contribute to a success of the thing. And the success itself is defined not just basically looking at the mitral valve area or the MR, but it takes into consideration LA pressure and RVSP as well. So kind of not just looking at anatomy of mitral valve, we have considered a combination of this, and recommendation for screening and selection of patient for a successful PTMC could be done, and prediction of MR could be done with very high accuracy and kind. This is where the Journal of Indian College of Cardiology this got presented. So ultimately, in conclusion, I would say kind of our experience has been we can work towards AI-based risk stratification system. It could be a good diagnostic support tool particularly in the rural or resource-constrained settings in the rural areas. And of course, in what it all means is for early identification, critical condition, and timely intervention can actually optimize patient outcome and reducing the disease burden as per the SDG requirement. So kind of we are aligned with the SDG requirement, and it is possible with machine learning and AI tools. So that's what it is. And thank you for the opportunity. Thank you for thanking all the organizers, and thank you. Let's work towards less of illness and more of wellness in the entire world. May peace be upon everybody. Thank you very much. Thanks for the opportunity once again.
Thank you so much for your excellent presentation, doctor. Are there any questions from participant side? I hope there is no questions for you. Thank
in Delhi, India, and I run this channel, Young India Intensivist, on YouTube, which is a free channel for critical care education. Now, I'm going to be talking about basic hemodynamics in terms of arterial pulse and tracings in the ICU. So something more dynamic, more acute, and really cutting the heart and the sword here. So if we look at how blood pressure began, it was in 1733 when Reverend Stephen Hales measured blood pressure for the first time. As you can see in the picture, he cannulated the artery in the neck of a horse, connected to a big glass tube, and you can see the blood rising. And for the first time, it was demonstrated that there is pressure in the blood that is there in animal and subsequently human beings. So today we are 300 years down the line, and we can now predict a fall in blood pressure before it can actually happen. And that is with the use of AI. So that is how things have progressed in the last 300 years. Progress in medicine is a slow game. It does not happen overnight. Now, a very basic slide I put up for you guys, that is the pulse. So we are all taught in medical school, medical college, always examine the pulse. And very sadly, this is dying out. So friends, please check the pulse, put the finger on the pulse, whether it's low volume 3D, indicating a low stroke volume, whether it's bounding, indicating a high stroke volume, whether there's a pulsus paradoxus is disappearing in inspiration, straight away telling you likely cardiac tamponade or maybe increased respiratory efforts, pulsus alternans, telling you there's a poor LV, dysfunctional LV, irregular pulse, telling you there's arrhythmia. And if you get a high volume pulse and the radial artery is feeling rigid, you know there's atherosclerosis. Now, this is just a 2-minute thing, and sadly, this is dying away. Now, in the world of AI, which is coming up very strongly, as long as you examine the patient, no AI can take away your job. But if you stop examining the patient, this might be a real danger in the coming time. So moving on to another very basic thing. So I'm trying to give you some pulse from my experience in the ICU. The patient is in the ICU and there is suddenly a tachycardia, sinus tachycardia, heart rate jumps to 130, 140. So there's this mnemonic I have kind of constructed myself, chip, VAD, cash. So here, you have these causes. So if you kind of go through this list here and try to focus on the patient, you get to know why there is a tachycardia. And you don't have to do a battery of investigations. You can then just proceed and focus on what is wrong and order the investigations accordingly. A very simple mnemonic, chip, VAD, cash. And this is not an uncommon thing. Tachycardia develops very often. And you can see the causes here: cardiac disease, disease cardiac output, ischemia, hypovolemia, inflammation, sepsis, surge, so common. Then the patient has gone to severe pain, fever has occurred, anxiety, which is not always discernible, drugs, catecholamines, you starting NORAD, tachycardia is occurring, and sometimes seizures. The seizures are not always overt, right? They are non-convulsive seizures. Patient has started bleeding, overt, silent bleeding in the GI tract, and shock is occurring, hypoxia, hypercapnia. So all these things, which there is a very big list, but this mnemonic can be very helpful. Now coming to hypotension. So we are very well versed with the idea that hypotension is accompanied by tachycardia. But if there is bradycardia, again, it's a clue to diagnosis. Very simple and very straightforward. So what are the causes? Beta blocker overdose, calcium channel overdose, amidrone overdose, or maybe not even overdose. Just normal dosing can cause such a situation in some settings. Then neurogenic shock due to something like a spinal trauma or a spinal anesthesia, or even a brainstem insult like a brainstem stroke, because the control is there for the circulation. Then there is mixed edema, coma, massive pulmonary embolism because of activation of basalt gyrus reflexes. So these are certain reflexes which are there in the ventricles and they cause bradycardia. Poisonings, cardiogenic shock, and I'm sure the audience is very well aware of this: cardiogenic shock, inferior wall MI, complete heart block, and so on and so forth. Neurocardiogenic syncope because of so many causes, and severe hemorrhage again because of basalt gyrus reflex. So this reflex is very important, basalt gyrus reflex, which originates in the ventricles and can lead to bradycardia in certain situations which are catastrophic. Now, coming to another clinical clue, can septic shock present without sinus tachycardia? We all know shock is accompanied by tachycardia. I showed you some situations, but that was not septic shock. Septic shock, we have all seen whatever field we are in, right? Can this happen without sinus tachycardia? So septic shock does not happen without sinus tachycardia. That is classic septic shock due to bacterial infection. Sometimes due to viral infection, sometimes due to fungal infection, there may not be tachycardia, what can be called a relative bradycardia. The situations in which septic shock does occur without tachycardia is if there's an intrinsic sinus node dysfunction. For example, there's a sixth sinus problem, sixth sinus syndrome, or the patient is again on beta blockers, calcium channel blockers, amidrone, patient is hypothyroidism. So these situations, if they are present, then the patient can have septic shock with a relative bradycardia. And these are the patients who should be given dopamine. That is the only indication to give dopamine in septic shock patients. That is if they have shock with bradycardia. Now, coming to another clinical pearl, from my experience, low diastolic pressure is considered synonymous with septic shock in 95% of the patients, or a vasodilatory shock. But please remember, there are many other causes. For example, any condition which causes systemic inflammatory response syndrome, such as acute liver failure, acute pancreatitis, can cause low diastolic blood pressure. Liver disease, inherently chronic liver disease, will have a low diastolic pressure, both because of nitric oxide. Severe anemia and thiamine deficiency are characterized by deficit of oxygen at the tissue level, so the cardiac output increases. And as a compensatory mechanism, the SVR decreases. And the low diastolic pressure is primarily related to a low SVR. Then again, in aortic regurgitation, to facilitate the forward stroke volume, there's a decrease in SVR, and we know the diastolic pressure can really fall in AR. And other causes of vasodilatory shock, and even in elderly atherosclerotic patients, there can be low diastolic pressure. We are all very familiar. We have taken the blood pressure elderly. It can be like 160/60, etc. And that is due to a reduced Wind-Kessel effect. I shall refer to that in the coming slides. Now, moving on to something which is slightly more technical and more advanced. How do we calculate the stroke volume with our monitors in the patients? So this is pulse contour analysis, and I'm sure this is familiar to everybody. This particular trace I've showed. In the black is the systolic portion part of the arterial trace, and stroke volume is calculated as K into pulsatility. Pulsatility is calculated by the software in the monitor, right? The patient is hooked to a monitor, and pulsatility is calculated by the software. And K is a constant which is derived from the demographic data of several patients, and it accounts for resistance and compliance. So the monitor gives you the stroke volume, and you know the heart rate. The monitor knows the heart rate, it gives you the cardiac output. So that is how it happens in the pulse contour analysis method of giving you the cardiac output and stroke volume. Now, here are some basic traces. That is the aortic traces, and you can see here there's a normal waveform on top, and below that there's a low contractility. So when there's a low contractility, it's the stroke slants, as you can see here. And there on the middle on top is a vasoconstriction. So when there's a vasoconstriction, the dicrotic notch moves upwards because the reflection waves come faster. You know, there's an incident wave, that is the ejection of the left ventricular stroke volume, which moves forward from the aorta. And as this moves forward, it hits the femoral arteries and the peripheral arteries, and their waves reflected back. And these clash together, and that is what gives rise to the dicrotic notch. It is not the closure of the aortic valve which gives rise to the dicrotic notch, as is mentioned in many books and as is believed by many people. That is incorrect. Right hand in the left hand corner below, you can see high contractility. So high contractility means that the upstroke will be sharper, and if it's even more in the amplitude, that means the stroke volume is even more. So by just looking at this trace, the arterial trace, one can make out what is happening to the patient. One can take a baseline arterial trace, and if something is going wrong, one can take the trace again and compare, because eyeballing is sometimes difficult. So if I will just read out these few points. If there is vasoconstriction, then downslope of diastole is slanting. If there is vasodilatation, then downslope is vertically down. Stronger the contractility, steeper the upstroke slope. Larger the amplitude of the upstroke, greater the stroke volume. Now, a small question for the audience. If they want to answer, they can put it in the type box. I can see it in the end. There is a problem with vasoconstriction and vasodilatation trace. Anybody wants to put it in the chat box, he is welcome. I will answer that. So here, that is the problem. The vasoconstriction is going to be slanting like this, and vasodilatation is going to be slanting like this, because the SVR in vasoconstriction is increased. So the diastolic runoff is going to be much more shallower. It's not going to be so smooth, right? It's going to take more time. Well, if there is vasodilatation, the SVR is reduced, so the diastolic runoff will be abrupt. So that is the answer here. Maybe some of you got it right. So let's move on. Now, this is taken from Hall's textbook of critical care, which is a classic textbook for critical care. It's a very beautiful trace here. So I'm showing this to you. So on top is the normal trace. On the left side is the trace for cardiogenic shock and hypovolemic shock. And what I told you earlier is what is being shown here. The upstroke is less, the dicrotic notch has moved up, and this is because the stroke volume is less and because the SVR is increased. In cardiogenic shock and hypovolemic shock, the SVR is increased, right? And if you look at right, there's septic shock. In septic shock, if you have adequately filled up the patient, there's going to be a normal or a high stroke volume, and the SVR is low. Thereby, as you can see, the upstroke is good and is going vertically up, is higher, and the dicrotic notch is moved down. So this is a very beautiful trace, comparative trace, and if you can actually understand this, it helps a lot at the bedside. Now, another misconception is all patients present with bounding pulse in septic shock. So this is classic teaching. We have been taught all this right from our undergraduate days, and even today it persists in the books, that septic shock is characterized by a bounding pulse and warm extremities. Is this really true? So more data has emerged now as people have realized, and their cardiac phenotypes in septic shock. So I'm showing you the results of a study which combined two echocardiographic data, echocardiographic data from two studies. And this is a dendrogram on the right side. This is not going to tell you too much, but if you look on the left, so here, if you see, there is LV systolic dysfunction in cluster 2, which is 17.7%, and patients with right ventricular failure, cluster 4, 22.5%. So together they make around 40% of the patients. Now it is understandable if there is LV systolic dysfunction as well as patients with RV systolic dysfunction, you're not going to get a good stroke volume. And if you do not get a stroke volume, which is good, you cannot get a bounding pulse, period. So you cannot always have a bounding pulse in septic shock, and we need to change this narrative in our textbooks and in our standard literature. Though the articles which are coming out now are very categorically telling what I'm telling now. But this should be realized by all, especially the students, the younger people, that all septic shock is not bounding pulse. Now moving on to something which is known as arterial pulse amplification. So as we move away from the central aorta to the peripheries, there is widening of pulse pressure. So the mean arterial pressure remains same. And this is because of something known as the Windcastle effect. The Windcastle effect is a classic model which has been used to describe this propagation or this amplification of the arterial pulse. So what happens is when the aorta ejects, when the heart ejects the stroke volume, it goes to the aorta. Now the aorta is a very elastic artery, so it expands, right? And it expands and it pushes the blood into the periphery. At the same time, reflection waves come back, and because of the incident and the reflection waves, you have this pulse pressure widening. So that is in a normal patient. However, in sepsis, this has not been shown to be true, and sepsis reverses the normal pressure amplification down the arterial tree. This was demonstrated in a very beautiful experiment here, and the tracings are there, but I will not explain this because I'm running short of time. But we should know this: in sepsis, the reversal of the normal pressure amplification, and even on vasopressors, this pulse wave amplification gets distorted. Now, pulse pressure depends on the stroke volume, the aorta elastance, and to some extent on peripheral artery elastance and resistance. The pulse pressure is less than 30 mmHg means low stroke volume, greater than 60 means high stroke volume. Normal small variation with respiration occurs because of the heart-lung interactions. Elderly often have hypertension with wide pulse pressure due to stiff blood pressures like 160/70 due to decreased Windkessel effect. And pulse pressure less than 40 to raise a red flag for low stroke volume in hypertensive or atherosclerotic patients. And if low PP is improving fluid, it implies stroke volume improved and hence cardiac output improving. Now, very important is pulse pressure variation, which we use to assess fluid responsiveness. And this is normally seen in a ventilated patient. But if you get pulse pressure variation in a spontaneously breathing patient, you can use this for fluid responsiveness with varying sensitivity, but a high specificity. So that's very important because assessing fluid responsiveness in a spontaneously breathing patient is very important. Now, moving on to this, why cardiac output is the only variable which tracks fluid response accurately, and pulse pressure, MAP, SVP are not good in septic shock. So one is baroreceptor reflexes which get activated, thereby activating the sympathetic reflexes when you push in fluid and the cardiac output increases and hits the aortic arch. Second is extreme vasodilatation. So even if you push in fluids, the blood pressure may not rise because there is so much vasodilatation. Then spontaneous changes in vasomotor tone can occur, and they can be altered compliance or autonomic neuropathy. The PPV is pulse pressure variation. It is more sensitive than stroke volume variation and systolic pressure variation for fluid responsiveness in septic shock patients. So PPV, that is pulse pressure variation, there's less inaccuracy and noise in its calculation because it comes directly from the arterial line, right? There's no major calculation required. But stroke volume variation requires pulse contour analysis, thereby there is some noise in its calculation. And for systolic pressure variation, it gets influenced by not only the heart-lung interactions, that is in terms of the respiration, but also by the intrapleural pressure, which directly increases the systolic pressure. Thereby, PPV is the most accurate determinant for fluid responsiveness out of all these three parameters for patients who are on the ventilator and are being ventilated with 8 ml per kg. Now, why flow track, that is uncalibrated devices, do not measure cardiac output accurately in shock? So there are a couple of reasons. Stroke volume is equal to pulsatility into K. I told you K is a factor which is a constant depending upon the normal population and accounts for SVR compliance. Pathologic states of shock and vasopressor use alters K, that is SVR and compliance. Hence, there is non-reliability. And absolute values of stroke volume are thus not completely reliable in shock. Follow trends like increase in cardiac output with these devices, and they can be used for calculating the cardiac output and the response in passive leg raising test. And Wessling was the first in 1983 to devise this formula. Now, we are coming to the end. So this is a very sophisticated way to test fluid responsiveness, and it has been devised by the great Professors Monet and Tibul, and it requires the presence of an automated bed and a cardiac output monitoring device. However, this particular thing is not available in most of the ICUs in the world, right? Most of the ICUs in the world don't have such sophisticated equipment. So what is to be done in resource-limited ICUs? So in resource-limited ICUs, in a normal bed, you should gently perform the maneuver. You should know the maneuver. Do not cause pain. Do not cause tachycardia because that will negate the test because that means that the sympathetic discharges have been activated. So once you do the maneuver, that is the leg raising, if you notice an increase of pulse pressure, you need an arterial line, okay? So if there is an increase in pulse pressure to the tune of 20%, or if there is a decrease of pulse pressure variation on the ventilator by 20%, that can be taken as a sign of volume responsiveness in these patients. So this is very important because most of us are working in resource-limited ICUs. Now coming to a blood pressure of 70/50, what inference can you draw for the type of shock? You know, one patient comes to you in the ICU, this is the blood pressure. So can you tell what type of shock this is? So people try to analyze and say, maybe this is cardiogenic, maybe this is septic. But because the diastolic is 50 here, a lot of people will say this is low diastolic, so this is septic shock. But look at the systolic. Systolic pressure is only 70. So the pulse pressure is only 20. That means the heart is not pumping enough blood. So when the heart is not pumping enough blood, your diastolic pressure is going to be low anyway. So you cannot say what this is, right? So most of the times you can say, but many times you cannot. This could be anything: cardiogenic, hypovolemic, septic, or other forms of vasodilatory shock. Now, moving on to this, having said all that, please remember that you have to know whether your arterial line is giving you the correct reading, the correct pressure, and the correct trace. In the only study, proper study that was conducted, it was seen that 21% of arterial lines were not working normally. So this is very important. All what I've said becomes irrelevant if your arterial line is not working normally and you are taking the readings from that particular arterial line. So with that, I come to the end of my session. Thank you very much. I'll be happy to take any questions.
Thank you so much, Dr. Tapesh. It was an excellent presentation. Is there any questions from audience side? Okay, thank
So
you.
any questions?
Our colleagues, strain imaging is an echocardiographic method used to assess the deformation of the heart muscle during its contraction and relaxation. It's important for detection of subclinical impairment of ventricular systolic function, and it's well known for better sensitivity and specificity compared to classical indicators of systolic function. We can use strain imaging for assessment of global function, also for regional contractile disorders. We have different types of strain, longitudinal, radial, and circumferential. We can use all of these types of strain in pediatrics, and we use this data for assessment of cardiac function. GLS, global longitudinal strain, is also well established as global.
Hello. Yeah, sorry for the interrupt. Your slides are not moving. Could you please check with your slides?
Okay. Can you see it now?
Yeah, it's visible, but it's not moving.
It's not moving.
Yeah.
Okay.
So shall we present your slides? Is it okay for you?
You can present it.
Yeah, fine. We will share your slides.
Okay. Okay, can I move on?
Is it visible to you?
Just a little bit.
Is the screen is visible to you, doctor?
Just a little bit. Yes, I can see.
Yes, you shall proceed.
Okay, can you move on? The next. Okay. And the next one. Okay. So GLS is a global longitudinal strain. It is well established as an indicator of left ventricular function, and we can use it in clinical practice for different applications. Please move on. Okay, now about advantages and disadvantages or limitations of strain imaging. On the left side, we have well-known advantages also in pediatrics. The method is non-invasive, is well reproducible and high sensitive, and it gives us a comprehensive assessment of cardiac function. But on the other hand, we have still some limitations, especially technical. We need appropriate equipment with enough technical expertise. And in pediatrics, we have also some age-specific considerations and, of course, lack of standardizations, especially lack of reference values for different age groups of patients. Please move on. So I would like to introduce main clinical applications that we can use in clinical practice for strain imaging. In congenital heart disease, we use strain imaging for early detection of myocardial dysfunction and also to assess the effects of viral disease on myocardial function. We can see in praxis that we use knowledge of strain imaging also for diastolic function, for assessing this diastolic function, and also for timely treatment decisions. Sometimes we use it also for post-surgical patients for assess the recovery of the heart after this cardiac surgery. Please move on. Next application is in patients with cardiomyopathies. It is very useful for early detection of ventricular dysfunction and also for decision-making process about additional diagnostics and timely treatment. On this picture, echocardiographic pictures, we can see different types of hypertrophy in amyloidosis, in hypertrophic cardiomyopathy, and also in hypertensive heart disease.
The topic of my presentation today is the role of atherosclerosis of coronary arteries in precipitating sudden death even in the young. Look at here, indeed, this is all the causes of sudden death in the young. The first one, indeed, is coronary artery disease, atherosclerotic coronary artery disease, not a congenital, like in an adult. And this is 18% of all these cases. We collected 690 in this period, and so it's a big number. This is the age interval in between 1 year and 40 years. So you see here the incidence among the age group. Of course, none under 10 years, but in between 12, 11 and 20 years, that is starting the cause of coronary atherosclerosis, and is increasing with time up to you see here is 70% of cases of atherosclerosis were within the age interval in between 31 and 40 years. Okay, so in other words, atherosclerosis is a cause of sudden death not only in the elderly, not only in the adults, but is maybe a cause of death even in the young. Okay, so look at this is the classical atherosclerotic plaque of coronary artery, which is the cause of sudden death. This is not the classical plaque with atheroma and fibrous cap. No, it's a hard plaque in the absence of evidence of cholesterol there. So, and how this plaque may cause sudden death, we will see later. Okay, so what is the culprit plaque in the young that precipitates sudden death? That is usually is a single vessel disease located in the proximal left anterior descending coronary artery, and the morphology of a plaque is smooth muscle cell proliferation, like a tumor, with a small or even absent lived core. And as far as what is the mechanism of occlusion of a coronary artery? No, it's not so frequent as in an adult. It's less frequent than the adult thrombosis. We will see that there is a functional mechanism that is occluding the coronary artery plaque. Look at here. This is when I do an autopsy or sudden death, both in young or in the elderly, the first cut that I do is in the descending coronary artery, proximal one, and indeed you see here with your eyes that the coronary segment, the proximal of the descending, may be occluded like that. So it's a very simple diagnosis mechanism of investigation. Okay, so this is the phenomenon that is typical of the young. It is not lipid infiltration, is not atheroma, is proliferation. Look at here, this is a proliferation of smooth muscle cells. Where are they coming? From the tunica media or in the lumen? Most probably, this is a transformation of the endothelial cells in smooth muscle cells. This is a phenomenon. It's not occurring in the elder. It's occurring very early when you are young because there are risk factors, and the most important risk factor, sure, is smoke. Okay, so sudden death. I mentioned that we have 790 cases that we studied, and among these 155 were atherosclerosis, coronary artery disease, as a cause of sudden death. And as far as what is the mechanism? This is thrombosis. Okay, thrombosis is in 39%, whereas 61% do not show thrombosis. They are purely proliferation. And as we will see later, this is a proliferation of smooth muscle cells that are synthetic, but they are also contractile. So, as far as the plaque rupture instead, the thrombosis, the remaining 39%, this thrombosis may be due, as in the elderly, plaque rupture, but is much more important and frequent is plaque erosion, which means there is no rupture of fibrous cap, there is damage of endothelium, and and this inflammatory infiltration, that is an inflammation that may account for endothelial detachment. And this is called the thrombosis because of plaque erosion, because of detachment of the endothelium. Look at here, this is a classical one. It occurs also in the young, but it's very rare indeed. This is the classical plaque with atheroma here, with fibrous cap here, and we know that this combination of the two, large atheroma, thin fibrous cap, is at risk of what? Rupture. Rupture because there is a release from macrophage of metalloproteinases with proteolytic activity accounting for the disruption of the cap, fibrous cap, and look at here, when you have the rupture of the fibrous cap, this is a condition sine qua non for having the thrombosis then here, and this is a thrombosis complicating plaque rupture. And look at here, and this occurred in a male 35 years old only, and you see that the fibrous cap ruptured, and there was, you see here, cholesterol cleft that are going outside and creating thrombosis and created lumen occlusion and sudden death. This may occur also in the young indeed, because this was a male of 35 years age, nothing else. Okay, and now the second mechanism of thrombosis is the endothelial erosion. This is, the theory endothelial damage is the starting of atherosclerosis, but is starting also of sudden death because of thrombus deposition there. Look at here, this is eccentric plaque. You see there is a thrombosis here, but the thrombosis was not created by a rupture of the plaque, was created indeed by endothelial erosion. And if you look at here, the endothelial erosion is due to inflammation of the endothelium, and this is the basis of erosion. And look at here indeed. But what is impressive, look at here, it's very important. This is another case of sudden death in the young, 29, because of thrombosis. But strange enough is that the underlying plaque was not with critical stenosis. In other words, there was no possibility to prevent this thrombosis because the patient was not affected by pain because of stenotic plaque. This is a thrombosis because of erosion, and look at here, due to per se the presentation of the disease causing sudden death. And look at here, what do you compare? The part of the endothelium of the intima, which is intact, and this was CD31 immunohistochemical staining. But you will see on the other side, where the thrombosis started, you see that indeed, you see these are endothelium, but detached, and detached because of inflammation. So the basis of endothelial erosion mostly is an inflammation there. We don't know whether this is infected. Probably no. Probably is immunological, but there is inflammation. And how many times we observed acute myocardial infarction in these cases of sudden death in the young? None. We observe, of course, wavy fibers. That is a symbol, of course, of ischemia, but it's not an overt myocardial infarction. Rarely there was a previous myocardial infarction that accounted for scarring, and this is 1 in 4. 1%, and in all the cases of sudden death you see here, okay, but not due to myocardial infarction acute. Okay, and look at here. This is a rare case indeed in the young. I don't know, it was a 39-year-old young, and you see here scarring. You see here the subendocardial scarring. This is a blue of atherosclerosis staining, and you see that this patient had so severe coronary atherosclerosis. But anyway, this is absolutely rare. Look at here now. The destiny of the plaque. You see here, this is a smooth muscle actin, you see here. So the majority of proliferation close to the lumen they are smooth muscle cells. They are mesenchymal cells, but smooth muscle cells. And as mentioned before, I believe that this is a differentiation coming from the endothelium. And look at here. This is the proof that proliferation may the cause of a functional obstruction then of the coronary lumen and accounting of sudden death. Look at here the story of this patient. He had chest pain. Chest pain, they did, you see, the coronary angiography. Okay, we are in descending coronary artery. You remember the artery of sudden death, as German pathologists say in the past centuries. And you see here, there is a stenosis. What happened? He was, during registration of the electrocardiogram, you see what happened. That is, there was recorded first the elevation of ST segment that is in keeping with acute ischemia, and then there was recorded the fibrillation, ventricular fibrillation. When we did the histology of this small segment, what we found? We found that the lumen was mostly occluded because of proliferation of smooth muscle cells, not a thrombosis or mural thrombosis. And don't forget that there are two types of smooth muscle cells. There is the synthetic type, the equivalent of blast fibrocyte, that is, of course, producing then the you see here that is proliferation of the cells, okay, but of synthesis, synthesis of extracellular matrix. But among the smooth muscle cells in the intima, and not necessarily in the tunica media, there are the second one, the contractile type, with a very peculiar immunostaining, different from the synthetic type. This contractile means not morphological substrate of the occlusion. It is functional because there is a contraction there, and this account for transient the XT segment elevation, which is in keeping with coronary spasm. So look at here. When we did indeed in this case in which we recorded sudden death, look at here. You see ST segment elevation, now transient, and then at the reperfusion of the blood, the was ventricular fibrillation and sudden death. This is the mechanism, functional mechanism, not thrombotic, of sudden death. And when we did the histology and immunohistochemistry in this case, we found just once subocclusion because plaque, subobstructive or obstructive class. And when we did a specific immunostaining, the contractile type of smooth muscle cells was found indeed in the intima. In other words, the intima and the lumen will undergo obstruction because of contractile activity of smooth muscle cells in the intima. Okay, so finally, conclusion. The plaque instability in the young may be either structural, with thrombosis, mostly due to erosion, or functional, due to superimposed vasospasm with vessel hyperactivity, because there are contractile smooth muscle cells in the intima as well. So this is the unstable coronary artery ischemia, and is structural because there is thrombosis. But this instead is functional, and both are instable. In other words, the coronary artery instability may be functional and may be morphological with substrate. So, the second conclusion, atherosclerotic plaque in the young, sudden death victims, shows abundant smooth muscle cells with a contractile phenotype. In the setting of critical stenosis, intimal smooth muscle cell contractility, together with a preserved tunica media, of course, might contribute to vasospasm and transient coronary artery occlusion, precipitating sudden death. This is a typical of phenomenon that may occur in the young. Thank you very much.
Thrombolytic drug, the 90 minutes, less than 90 minutes in the emergency room to the balloon, and less than 120 since the symptoms onset to reperfusion. Here is a graphical representation of what it should be in practice. Onset of symptoms, ambulance arrival, a pre-hospital EKG, and hospital arrival, and hopefully reperfusion if the cath lab is available. During all this time, there is an increasing loss of myocytes. Time is myocardium. Unfortunately, this network doesn't work or doesn't exist in many countries, and particularly in the less developed ones. Next, please. As we already said, time is myocardium, and this is a graph which shows that after an STEMI, there is the 1 year mortality increases 7.5% for every 30 minutes of delay to perform primary PCI or thrombolytic therapy. Next one, please. This slide shows a meta-analysis of prospective studies on relationship of door-to-balloon time and clinical outcomes. Door-to-balloon time represents only a small fraction of the total ischemic time. The total ischemic time is since the beginning of the symptoms to reperfusion. And 32 studies involve almost 300,000 STEMI patients, and the longer the door-to-balloon time, more than 90 minutes, had a higher short-term and mortality and long-term mortality. A stronger effect among those with shorter pre-hospital delays. So it is extremely important to optimize the pre-hospital processes. Next one, please. 12-lead ECG is in the center of the decision to evaluate and to treat patients with chest pain. For the American College of Cardiology and American Heart Association, Class 1 recommendation to perform a 12-lead ECG in the site of the first medical contact. There is enough evidence that the pre-hospital EKG accelerates the route of the patient to treatment, shortening the time the first medical contact to reperfusion. Places of the first medical contact not always have trained staff able to make a correct ECG diagnosis. So telemedicine allows STEMI diagnosis in the place of the first medical contact registered in a 12-lead ECG, sending the signal to a specialized center and getting the report back in less than 10 minutes. Next, please. This graph shows the importance to skip the emergency department evaluation in the hospital. And here you have that the pre-hospital, when the ECG is performed in the pre-hospital place, they are more likely to receive the reperfusion if you compare with any other clinical variables. So it's extremely important, the performance of the pre-hospital EKG. Next one, please. This graph shows the importance of to skip the emergency department evaluation in the hospital when the patient comes from the place of the first medical contact. 31 minutes in yellow are saved if this stage is skipped and the patient goes straight forward to the cath lab. Next, please. And multiple studies have demonstrated that the implementation of the pre-hospital ECG decreases the door-to-balloon time in 15 to 20 minutes, and the door-to-balloon time less or equal to 90 minutes has been achieved in 86% of the STEMI patients when the pre-hospital EKG was used. An in-hospital mortality rate of 8% when the pre-hospital EKG is performed versus 12% without. The next, please. And here it comes telemedicine. Telemedicine in Chile we have a teleelectrocardiography, no, the previous one, friend, a teleelectrocardiography service running for 20 years already, and equipment used to have the EKG taken is a very small size, able to acquire a 12 lead ECG, and they are distributed all over the country in 650 places, 500 depending on the Ministry of Health, and some in very remote places, including the Easter Island. This system facilitates decision-making, avoids unnecessary transfer of patients, and allows immediate initiation of the treatment when necessary. And there is a more precise ECG diagnosis since the reports are made by a specialist on a 24/7 basis. In our telemedicine centers, we receive around 60,000 ECG a month, and all the reports are stored in a database. And the report of the cases with the chest pain have the highest priority and is sent back within a maximum of 10 minutes. Next, please. In Chile, we have a law, not a recommendation, but a law called the AUGE or HES. The translation would be universal access with explicit guarantees. And the universal access with explicit guarantees, there is a list. More than 80 diseases have a predetermined time to complete diagnosis and treatment by the health system. Next, please. How this law applies to the myocardial infarction. A patient with a chest pain suggestive of ischemic origin must have, by law, an EKG report within 10 minutes of consultation. The treatment protocol is of the Ministry of Health with the support of the Chilean Society of Cardiology, and telemedicine is the tool for the ECG diagnosis. And patients should be referred for primary angioplasty if within the time limits, or thrombolysis should be initiated in the first medical contact. Place. The next, please. Here is how this works in the case of consultation for a clinical picture suggestive of acute coronary event. The EKG is acquired at the primary care or the first medical contact or emergency service, is sent by the phone or mostly by internet to a call center. A technician validates that is technically correct and is immediately sent to the cardiologist's computer. And the report, which takes only a few minutes, since the ECG diagnosis are set up in the system with all the usual measurements, and is sent back to the place of origin and to a reference hospital, which is coordinated with the ambulance system. Next, please. The impact of this system has been very important. This is a very preliminary analysis, and the global mortality applying the system decreased from 12 to 8.6%, adjusted by several factors. The reduction was rated, the rated reduction of mortality in patients with higher risk, women and older than 75 years. In patients treated with thrombolysis, mortality decreased from 10 to 6%, even in hospitals of low complexity. And there was a significant increase in the prescription of statins, beta blockers, ACE inhibitors, and aspirin. Next, please. The strategy for STEMI treatment in Chile is based on the existence of a law, the HESTOR, that compels to an early diagnosis and treatment of STEMI, and the ECG must be performed in the first 10 minutes of consultation for chest pain suggestive of ischemic origin by law. Guidelines for STEMI treatment are of the Ministry of Health, distributed by decision of the state throughout the public health system. The support of telemedicine for early diagnosis and the implementation to perform thrombolysis even in rural areas. Next, please. Next. This represents a real photograph of different cities of the world, showing the difficulty for transportation of the patient, and cities in Chile are not an exception. Next, please. Therefore, the protocol of STEMI treatment considers a pharmacoinvasive strategy. This protocol, and you see here that we have at least 180 places, even rural, where thrombolysis may be performed. And after the procedure is performed, high-risk patients are referred to a hospital of tertiary level for further treatment. There is a network of referral hospitals according to a geographical location of first medical contact or emergency room. If the referral hospital is able to perform PCI, emergency department is skipped. The patient goes straight forward to the cath lab. Next, please. This protocol was later expanded to a well-organized system in 3 other countries of Latin America. And this graph shows the hub and spoke organization. Different spokes at primary level, a patient with a chest pain suggestive of ischemic origin, the ECG is taken, is sent to a telemedicine center where a cardiologist, a very well-trained doctor, makes the diagnosis, and the ECG is sent to a hub, and by the ambulance is called for transferring the patient to the hub, and where the PCI facilities exist, and bypassing the emergency room. So you save at least the 31 minutes I showed in a previous slide. Next, please. This is called the Latin protocol, with the 3 components: the first medical contact or spoke, the ambulance, and the hospital or hub. Each spoke has an ECG device connected to the telemedicine center. The ECG interpretation is made by remote cardiologists. Time to the telemedicine diagnosis was only 5.8 minutes. The telemedicine center has the capacity to transmit the diagnosis simultaneously to the 3 places and give clinical advice. And the primary PCI is available in all hubs. A pharmacological treatment initiated in the ambulance is a practical strategy, including the usual drugs that everybody knows. Next, please. This is the results of the Latin protocol. 3 countries, Brazil, Colombia, and Mexico, 224 centers, and more than 400,000 patients. The ECG diagnosis by telemedicine, more than 4,000 STEMI. 95% of the diagnosis was a specificity and pharmacoinvasive strategy, as we already said, and mortality was only 4.8%. The next, please. So the telemedicine is an important tool for organized networks of diagnosis and treatment of STEMI and other cardiac emergencies. Next. and the implementation of well-organized systems of pre-hospital care with telemedicine support will help to the objective of saving more lives and preventing unnecessary disabilities. Thank you very much for your attention.
Thank you so much, Dr. Edgardo. It was an excellent presentation. Is there any questions from audience side for Dr. Edgardo?